Deve entrare.
Esatto.
Truth or alternate?
Right.
Very taxing. Maybe.
We went to Turkey and we
Live low.
Uday Kumar Reddy.
కొంతమందికి నాకు తెలుసు మీద చాలా మంది తెలియని పూర్తి కానీ అందరినీ అడిగాను చెప్పండి
గారండి
నాకు ఇద్దరు అమ్మాయిలు ఒకరు కూడా మెడిసిన్ చేయమంటారు ముగ్గురేమో గ్రాడ్యుయేషన్ చదువుకుంటున్నారు. నేను 75లో స్టేట్స్ వెళ్ళి ఆల్మోస్ట్ 40 years డయాగ్నోస్టిక్ ఏరియాలు చేసి రిటైర్ అయ్యి హ్యాపీగా హెల్తీగా ఉన్నాను ఇప్పటి వరకు. ఈ తర్వాత ఎవరికి తెలియదు కానీ ఇంతవరకు బాగా ఆ ప్రొఫెషనల్ గా నాకు బాగా హ్యాపీగా ఫీలింగ్ వచ్చేస్తే 40 సంవత్సరాలు రెసిడెంట్స్ కి టీచర్స్ కి స్టూడెంట్స్ కి టీచ్ చేసే అవకాశం నాకు కలిగింది. దానికోసం బెస్ట్ పార్ట్ బాగుంది. ఇంకొకటి చెప్తా ఇవాళ 60th నేను ఆల్మోస్ట్ ఒక ఇయర్ ముందు 21 ఇయర్ నుంచి ఎందుకంటే ఆల్మోస్ట్ ఇయర్ అగో వాట్సాప్ గ్రూప్ స్టార్ట్ చేశారు. సో మన ఫ్రెండ్షిప్ తిరుగుతూ వచ్చింది. దానివల్ల ఈ 4 రోజులు ఫైనల్ యాక్ట్ అనుకుని లైక్ థ్యాంక్ యూ.
Friendly, we care for each other, we joke with each other, we never did before. చదువుతున్న రోజుల్లో ఎప్పుడు అలా what is the difference between psychotic, neurotic, and psychiatric? Psychotic, neurotic. Psychiatric.
Psychiatric, economic, and psychiatric.
Psychiatric.
Okay. Now, illnesses. Now, if you broadly learn it, in neurosis, the individual knows what is wrong. I have palpitation, I have gastritis, I have numbness, tingling, whatever. So in neurosis, they know the symptoms. What they don't know is the cause. In psychosis, these people experience certain unusual happenings and they interpret the happenings wrong according to us. I can hear the voice of God and that's hallucination. Would say, I don't hear anything. But at that particular moment in time, both individuals, the father and the son, have not lied. They have said the truth. The one who hears has said the truth, and the one who has said he has not heard has said the truth. But at that moment in time, two people are saying two different things. Now, how would you explain that other than an illness component here? There's something that's not something and that hallucination is something. If you take our community, I'm sure most of us believe that what we don't see. Example is God. God we don't see. God is powerful. God can do all manner of things. That's the belief. And you believe it or not, I mean, it's up to you. But common belief is that God you can't see. Some people say that they can hear, that is how it is, it stands there. You know, you can't argue that. But then, when you take this psychiatry and psychosis, who will you believe? The person in front of you who is a human being or the voice of God? We will believe the one that we have not seen, isn't it? So that is why that person's behavior becomes unexplainable. Why did you suddenly, for no reason, why? Ask him, he will say, what? He heard the voice of God. And what the other thing about psychosis is difficult to understand is, now if you have tasted that, it is a movement that think about a plan that I am going to do tomorrow. And then after half an hour, I say I feel tired. Would any of you believe me? Be honest. Don't it? Now tiredness came because I was thinking. And that consumes energy. Can you see anything? We are all brought up to believe that what we see or what we think is you're wrong or I'm not arguing with you. But it's just the way we are. When you see this man, easiest explanation. Call him crazy. Yes, the medicine. No. I'm patient. No, it has happened many times. Consultants, dermatologists, consultants, whatever. But in my room, this is just my name. And I said, what have you done here? Consultants, I can put it that's not possible. Because these people sit in the line and they read that. No patient. And you know why it happens? It's a very simple explanation. This person is treating, I am not treating. So why you have to do that person? And the other thing that is very, this is very difficult from a physical person. In the physical person, you will realize either you have palpitation or you have shortness of breath or you have cough or fever or headache. The person actually experiences those symptoms, isn't it? Haven't you experienced it? Now when you experience it, is it difficult if your wife or husband says, come, let's go and see a doctor. You go and see a doctor and you give those symptoms and the doctor takes a piece of paper and then take a WBCDC, do an X-ray test, do a scan, do whatever else. Come with the result. And you come with the result and he looks at it and he says, yes, this X-ray, there is a density there. That's the focus. So you have actually seen it. When you see it, won't you believe it? Then next he says, take this medicine for the next 6 hours, for the next 1 week, you'll be fine. And you take it for just 3 or 4 days. And what you do is, though you have medicine for 1 whole week, you take it only for 4 days. You're fine, and you do not take any other. You don't take it, you're alright. In case of psychiatry and psychiatric patient, what happens is, this person is rather disturbed in his behavior. He is argumentative, aggressive, violent. And the family around him have had enough. So what they say is, you need to be taken to a doctor. So what they do, they get all of them, 4 or 5 people. If they can manage, they will tie his hands. If he can walk, we might tie his legs and bring him to the doctor. And now he sits and the doctor is there. The doctor says, what is wrong with you? And guess what he says? There's nothing wrong with me. Ask them what is wrong with them. You know? So then, the doctor has already asked the patient, and he has not said anything, that you have to ask other people. So they ask the other person. When they ask the other person says he is violent, he doesn't listen, he is argumentative, he is talking about hearing things and all kinds of things they say. The doctor, of course, diagnosis, as I said, schizophrenia, and then prescribes medication. And then these people take him home, they go to the pharmacy, buy the medication, and look at the medication, and it's time to give the medication. They take it out and say, here you are, 2 tablets, doctor said to take. Guess what the patient says? Can any of you just went to the doctor, you took me, he spoke with you, you spoke with him, he wrote medicine, you took the medicine went to the pharmacy, you bought the medicine, and now you have the medicine, why not you take it?
Makes sense.
Makes sense? Isn't it? What happens? So actually, it's not an easy thing to get and treat a patient who is having this psychiatric disorder. It's very difficult to get. So you have to know what I do. What I do is, I don't ask any of the relations. I ask him, what happened? What happened? Then he or she always says, will you believe me if I say what happened? I said, I always believe my patients. And this is how I get to square one. You can't oppose your patients. I mean, I'm sure all of you have this experience. It's just that you have to have the patient's cooperation for that patient
To get better.
get better. So this is what happens with that, And other thing about the common people, the community is that if this psychiatrist can treat this mad person, isn't there a saying that says, you can, if you understand that person, that you are on the same wavelength. Okay? You agree? Same wavelength? Alright. And if that man, and if you can understand him, then you also have to be mad.
Usha, you are telling them and asking them questions, you feel neglected.
Sorry.
Are you saying that you need more than a...
You feel neglected because she's talking to them, she's asking them questions.
So this is normal behavior. No, this is normal behavior.
What's the same there with
You know what it is called?
Water.
Neglect.
Indian necklace.
That is what it is.
Sir, what
No. This is normal psychology. This is normal psychology. No, but there are no children.
Corrected.
In a family, there are 4 children. Now, the parents make it, we love all of you equally. Does it happen?
People goodness. They definitely.
It doesn't happen.
I-
And your behavior shows it. And in this Asian community, for whatever reason I don't know, and it just happened now here also, that we concentrate on the males rather than the females.
Being a female also you did that.
Exactly. No, exactly the point. That's what I'm saying. I include myself. So, what I'm saying is human beings is like that. But who will accept it? I don't think anybody will accept it. Because in our own minds, we have this image that we are good people. We are good people. We are honest people. And we are fair people. Really fair.
Depends on what you mean.
I'll tell you. You have 2 people come, so then you make it into 4. Do you think you can cut that piece of cake exactly into 4 pieces? And then if I accidentally pick up the big piece and give to her. Talking about the human mind, psychology. This is psychology. Because what we think is what we do. And most of the time, we will do the way we want to do it. And when it comes to doing something wrong, like jumping the queue or something, you will explain to yourself, this is the first time I'm doing it right. Do you agree with me or you don't? Exactly the point. But when you're saying it, you will say that I'm a fair person. But am I?
Usha, she asked you a question, you are asking us now.
No, the thing is, it's exactly the point.
Guide us. I must say instinct. Case study.
No. Instinct is something that you do as an impulse. Okay? Agree? Now, if you do it according to instinct, according to the psychology studies, 5% it is right. 5% is right. But then one must remember 95% is wrong. Instinctively do things. DMC 64.
And take the next call.
3-minute story.
And he went for haircut. The barber was so irritated. He had only 8 hairs on his head. And the barber asked, do you want me to count or do you want me to cut? And in Naudu, I want you to color it again. To start with a lot of things. From life to humor to philosophy to religion to everything. And he wanted that not take down. పొరపాటు ముందు సెలవు తీసుకుంటే they will cancel it and they will say, in that 20-30 minutes he is with me. For any reason, if you are down here, by the time he leaves my office, you are up here. 65 రిటైర్ అయ్యాడు రైతుల నుండి. అప్పుడు వాళ్ళ అల్లుడి ఇంట్రడ్యూస్ హిమ్ టు గాడ్. He took lessons. He plays. He had a hole in one. Local newspapers wrote it up. He called the daughter, get me a newspaper. Dad, you get a paper, why do you need one more? Oh, I want to give this to Dr. Babu. Why can't you copy it? No. You can't give a copy to Dr. Babu, there is nothing. So the daughter went got the paper. Next time when he came, everything he got gave me the paper clip from local newspaper. I still have it. That is the beauty of being a doctor. As you made a comment this morning, the scientific part of medicine is limited. The most I enjoy is the human side of the medicine. That is what taught me a lot about life. That is what taught me to know about people, how to communicate with people, how to deal with people. That includes part of my teaching. I learned a lot from my students, from my book graduates, from my fellows. And that interaction is one where I don't think any other profession has. There are only two other things I can think of. A bond between a teacher and a student, and a priest and a parishioner. అదే మనకి చెప్పాలంటే మన పురోహితుడికి మనకి ఉన్న సంబంధం ఇప్పుడు అన్ని పోయి పూర్వకాలంలో చాలా పెద్ద ఉంది. జనార్దన్ రెడ్డి రావాలి మాట్లాడాను, నిన్న రాలేదు కాబట్టి ఇవాళ అరగంట మాట్లాడాను.
Before yesterday, we had a very severe storm in Houston. So our flight got delayed in Houston itself. Meanwhile, one gentleman checked it, but he didn't go into the flight. So they had to check on him, they couldn't find him. So they have to take baggage off from the flight. Baggage off the flight. But anyhow, started late 4 hours and they were initially connecting flight. So I came late yesterday. And I have a place here in Houston, no, in Guntur. And you weren't here, we came here about 6 years ago. So you know how the house works. I don't visit stuff. So we took some time for that. But anyhow, my wife Bharati is here, and I have 3 kids. My daughter Sandhya, she is an anesthesiologist. My son is OBGYN doctor. I always wanted to do OBGYN, but I didn't do it. But my son picked it up. I ended up with Padma, who is the teacher. That's my story. We truly will have a good time. Krishnaraja, what is the difference between an internist, surgeon and pathologist?
Two radiology and then pathology, third pathology. These three are considered to be toughest specialties in practice.
It is there in the body.
Psychiatry always fascinated me. In fact, the next day I was to join. There were 48 people who were competing for 2 seats, and I was one of the 2 who got the seat there. Right? When I came back, the professor of medicine surgery, everybody called me and scolded me right and left and center and said, you have no brains, why do you want to go for psychiatry? So I went to Professor Shankar, psychiatrist. He was a good friend of mine as well. Later on, he became my patient also. Right? And he became patient of himself subsequently. No, unfortunately, he developed Alzheimer's and passed away last week. He said, okay, first do internal medicine like what he did. That's it, then you go for psychiatry, you'll be a better psychiatrist. He also did that. It was an MD in internal medicine. He did his diploma in psychiatry and became a professor. That's how I landed up in internal medicine, thinking after that I'll go for psychiatry. So with that in mind, I went to All Institute of Medical Sciences to join psychiatry. But then the admissions were already over. So the director of the institute, because I topped in that examination day, he said, we want you to have here, but admissions are already over for psychiatry. So he said, you join internal medicine because you're already in internal medicine. So next year you can take up psychiatry. I was there as a emergency physician for 1 year in the emergency room. Then I observed what was going on in psychiatry and I wasn't impressed at all. That was not a great institute for psychiatry. You should be knowing it better. So then I applied for cardiology and gastroenterology. The cardiothoracic surgeon was Professor Gopinath from Andhra Pradesh. Right? He was the father of cardiothoracic surgery in India. So he was very keen that I should go into cardiology. So I applied for cardiology. But in fact, I wanted to go for gastroenterology. So I applied for both. Right? Interview. Director Anand Stone was there, and the cardiology department chief, gastro chief, somebody else, registrar. When we were waiting outside, the registrar came out and told me, did you apply for 2 specialties? I said, yes. Then I have an advice to make to you. Because I treated his son when he had some injury and I was in emergency. And then I treated him and did some suturing, antibiotics or whatever. So he had a soft corner for him. Then he gave me an advice. If you apply for 2 specialties, both of you then think that you are not committed to either of them. So both of them will not take. So he said, you withdraw one application. So I withdrew one. It happened to be gastric. So I became a cardiologist. Not that I wanted. Very good.
Why did fast?
But it is good. In fact, the first place I never wanted to come to medicine, I told yesterday. I wanted to teach Shakespeare. That was my passion. I couldn't do it, but at least I could teach cardiology. Now coming back to the question, so internal medicine is tough. So these days there is a serious shortage of internists. I don't know about it, but here in India, very serious. Everybody is going into a specialty, nobody is going into internal medicine. But now things are slightly better because here now the ICCU, emergency care, are looking at the intensives. So these physicians are better. But till 5 years back, it was a difficult specialty. We were not finding people who were going into various specialties. Now in, at least in the country as a whole, and also in Hyderabad and that region, when they apply for post-graduation in subspecialty, the top one now is medical oncology. It used to be cardiology for many years. No longer so. It is medical oncology. And then next is nephrology. Third is gastroenterology. Okay. Fourth is rheumatology and medical specialty. Now, neurosurgery, nobody is interested. Cardiothoracic surgery, last 20 years, not even half dozen people join. So there is the same thing is happening in India. So when this generation of cardiothoracic surgeons stop working, they have no experience in cardiothoracic surgery. There will be huge gaps. Then of course, the part of the problem also is a lot of the cardiology work is taken away by the interventional cardiology. Angioplasties, structural heart interventions like aortic valve replacement, mitral valve replacement, so on and so forth. Pediatric cardiology is taken away by the pediatric cardiologist, Arrhythmic medicine has been taken away by the EP cardiology people, and then structural and coronary has been taken away by interventional cardiology. There are no true cardiologists anymore. You know, the interventional cardiologists probably now many of them. The future generation may not even know how to take a blood pressure. They don't examine it all. They don't examine it. So, but anyway, I'm diagnosing probably. So the things are changing very fast. But pathology, coming back to a different area, pathology. Now I was a university gold medalist for MBBS pathology. And I was also a gold medalist for combined pathology and microbiology. In 1968, 67, something. Then I got to my MBBS. So, the Ramalingam Swami died in Usmania Medical College. They went on coaxing me. Those days there were no cell phones, so writing letters. Letter after letter for about 2 to 3 months. Till I joined my internal meds. So, I got interested in pathology. Somehow I thought it was I mean, it doesn't give you the, I don't know whether there is a pathologist here. Probably not, but it doesn't give you the adrenaline of medicine and surgery. It is a very old specialty. We are dealing with basically dead things, you know, dead tissue from a living person or dead tissue from but same with radiology.
No, there is no communication.
But even for
I mean, there's no interest, they're not.
even radiologists had a similar problem till recently until they entered interventional radiology.
Different from interventional radiology.
They just didn't know anything about patients, so they were very impersonal. They're not responsible for the diagnosis. So wait, so that they make at least some mental comment that. But after interventional radiology has come, things are somewhat different.
Mammography is another.
Pardon?
Mammography is another area where you are in touch with the patient.
A subsection of radiology. But we are talking about general radiology. Patient walks into the radiology department, I tell you what happens. What happens in radiology department, I know. The patient walks in, pays, takes the bill to the radiology department. The receptionist takes the bill, sends the patient in. Then the technician will take over. He will do the procedure. Then the radiologist will from his chambers report on the screen from the computer interconnectivity, intranet, and then it is typed, goes to dispatch. From the dispatch, it goes to the patient's hand. Then it goes to the clinician, referring clinician. Referring clinician never reads the report. Never. I would say almost 85 to 90% of clinicians don't read the report from A to Z. They will only look at the conclusion. That's all. So there are many mistakes in the diagnosis, many mistakes because they stopped reporting my X-rays in my radiology department. So I tried to tell them where they were wrong. Reporting my patient's CTs, my patient's chest X-rays. They don't. Then they tell the patient, when the patient asks, where is the report? They think, no. Because he also knows how to interpret, so he would need our report. Right? That's what is happening till today. They don't report. MRI, even cardiac MRI, cardiac CT, PET CT, chest X-ray, everything, I have to see myself. They refuse to report. But they don't like to learn. You know, cardiac imaging is something which can be done much better than by a cardiologist than a radiologist. The reason simply being, as a clinician, I know the clinical background of the patient. I know the basic investigations. What is the, differential diagnosis, data and down diagnosis, what you are looking for. So that, and I know the cardiac anatomy better than anybody in the world. In the sense, cardiologist. And we know the cardiac physiology better than anybody else. We know the cardiac pathology better than the cardiac pathologist. Incidentally, I used to do cardiac autopsies in Vijayawada. Cardiac autopsies of congenital heart disease, where they did not have a diagnosis. Like Emma used to do, maybe don't mind. My mom was 2 years junior to her. She was a pediatrician. She used to send her kids. I would do the cardiac autopsy. So what I'm trying to say is clinicians can be better radiologists than radiologists. They are good in physics. They are good in radiation physics, MRI physics and things like that. But when it comes to clinical radiology, clinical MRI and CT, the specialist can do it better than that. That is my personal opinion. But I do it myself. And I started the Department of Cardiac Imaging in radiology. I was the CEO of the hospital. So the radiologist could not say no. Because I was controlling the patient. They couldn't do anything. So I started cardiac imaging. 2 cardiologist administration there. I sent them to, one of them I sent to Boston. One of my students, Shabila Gorbala, she is a cardiac, nuclear cardiologist in Boston Brigham. So that student of mine stayed with her for 1 month. Then she in turn sent him to MRI center in Brigham. Then he got trained there. Then from there we sent him to San Francisco for coronary CT. Now he is running our cardiac. This is one of the very few hospitals in the country where cardiac imaging is done by the cardiologist. Now this is being done in few more hospitals, but we are charging it separately. MRI, they are looking at the organs. And the easiest thing in radiology is reading a CT and MRI. Is it normal or not? Is it a mass? No mass. Or any mass is that's it. But just is the toughest. Because you are reading shadows with an indirect information. It is like a ghost you are looking at.
Like you can do what you have been doing.
Very few.
My straightforward answer is
That's one question I will raise. We're not just looking at the heart, we're not just looking at the bones. So we're looking at the whole picture of chest X-ray. Right? So that's where the differences come. But you have a about it. So that's what I admire about you. And but how many cardiologists will do that?
no, I do generational change. I can't compare myself with the current
Right.
cardiologists who are they have subsectionated, subsegmented. Somebody is doing only coronary work and nothing else.
You definitely extended your knowledge base beyond just heart.
So in my home,
And advance your
Deputy Prime Minister, I was the first one in Andhra Pradesh to do a cardiac CT, very new technique which was published at that time, not like what they are doing. Then I was the first one to publish a cardiac MRI in India. I did my cardiac microscopy as a dissertation for 1 year.
I really admire, accept all those and admire you.
And I'm giving the next thing. So we cannot compare a particular generation of specialists with another generation. So things do change. I start my practice reporting X-rays, IVPs, and then
You have a unique experience because what you went through. Same thing, I am a surgeon before I became a radiologist. So I have unique experience in my hospital as an interventional radiologist. So even an interventional radiology fellow cannot be as confident as I used to be because of my can compare with you.
I don't want to. Those were different times, these are different times.
Exactly.
So I may not be a great interventional cardiologist of current generation. But then I was the first one to take coronary angiography. And the first coronary bypass surgery was done by PV. PV is first coronary bypass. He did the first bypass surgery in Andhra Pradesh without coronary angiogram. right? They would just palpate the coronary artery and see where there is a tough thing, put a graft beyond.
Music program
So one of his own friends had a formed. Right? There was no angiogram. He had an aneurysm, aneurysm. So he operated on him. CABG and aneurysmectomy. He survived for 4 days, did well. On 4th day, if I remember maybe right, correct me if I am wrong, he developed a refractory ventricular arrhythmia and passed away. So the disease was done by him.
Yeah.
First successful award done by somebody else. So maybe when he talks, probably we'll talk. But things do change. We went through tough times. When I was in National Institute, we were doing just about 2 catheters a day. Now, I mean, Care Hospital, for example, there were days when the entire group had done 70 a day, starting at 5 a.m. and going up to 1 a.m. 70 a day. Though now we do about probably 15 hours.
Well, my point is, it also depends upon your background and the learning experience. You know, like when I did residency and another 4 or 5 years, so it's 8, 10 years of postgraduate training. That makes me a different person. You know, I can't say doing MS was a waste. So your experience also, you have extended yourself beyond cardiology into different aspects attached to cardiology.
Physiology,
Right.
pharmacology, pathology.
Right.
So I think those foundations were probably that's a unique cardiology many times maybe. And also my training in R&D Institute, every Saturday we have a meeting with the radiology chief, cardiothoracic surgery chief, cardiology chief. I have to present that week's CAT data, read the ECG, read the X-ray myself. It would be corrected by the chief of radiology, named Bhargava. She was the head of the department of radiology. That I haven't seen it will depend on to be she was a personal friend of Prime Minister how many radiologists you know have ever attended an autopsy of a patient who they have reported? I don't know, you need to tell me.
No.
But she would attend, she will make it sure that she attends the autopsy.
Cardiologists attend those things, like you attend.
Because we have 1 month working in pathology.
You have a unique experience in a cardiology related field. But how many cardiologists do have a similar experience? So that way the difference comes.
So, Sneh Bhargava was just an anecdote, just to prove that one of my colleagues got an X-ray done of a cat, put it up during the cardio-radiology session. Then, less than a minute, he said, "Are you trying to fool me? This is an X-ray of a cat, not a patient." He was a patient. And she would go to every autopsy, when she cannot go, she would send her somebody, they had to come back and then she was an examiner for neurosurgery, she was an examiner for neurology DM, she was an examiner for gastroenterology DM, for the inhaled instrument. I know, everybody cannot be saying what she was that good. She wanted to be a surgeon in fact. Sneh Bhargava
One example, that Carlson is considered father of pulmonary and all. He has his own way of evaluating those things from a perspective. So it depends upon the individual experiences and how they extended themselves also.
So, she was because she was shocked until reached the operation table. Those days, the adjustable heights were not available. This is from the height. She was denied. She was very upset. She went into radiology, very proud subject of those. And this is from all the any hospital. But she went on to become one of the greatest radiologists. Surgeons. Surgery basically is a skill, you know. It's a hand skill. You can be a great surgeon with experience for a period of time. Like you are good in doing a SARVA, right? So you can be a good sambar and then you can do this good biryani, things like that. So surgeons also over a period of time, their hands will step. So to operate on themselves will be fundamental. Because they are learning hands. It is not intellectual. Surgery is not surgery. As Gopinath was mentioning, who made me go into cardiology, and his other consultants, they went for Dr. Ian Rao, the leading cardiothoracic surgeons. Their knowledge of cardiology was super. Cardiologists cannot match. And we have had cardiac surgeons coming from New Zealand, Australia, and also United States. Their knowledge of cardiac anatomy, physiology, pathology is something which even the medical cardiologists do not have. But that generation is gone. Now cardiothoracic surgery particularly has been boiled down to just doing coronary bypass, which is like doing most. I'm saying almost. Why I'm saying that is, there are some of my patients who are psychologically who are attached to me and dependent on me. After evaluation, you need the closure of ASD. I also practiced pediatric cardiology for almost 30 years. But now of things I don't know much of that. But I was a very busy pediatric cardiologist for many years. So when we tell them you require a BSD or you require a bypass surgery, or they will tell it, if you are doing, we'll get it done. I said, if you want, I will do it, but 100% guarantee, we will not do it. Because I am not a surgeon. I am a medical student. So, only a proper surgeon can do the job. So, coronary bypass surgery has degraded the cardiac surgery because coronary bypass surgery has become so routine. You know, in some of the centers in US like Texas Heart Center, I understand I had a few articles on dental policy and litigation capacity. So their operation theaters were doing something like 100, 120 or 130 a day. There were some 20 operation theaters, something like that.
They just do this finish up.
I know, Ravi took me there. Dental policy was operating at the age of 82 years.
Right.
I went there to give some lecture. He took me there because I know my dental policy from his visits and my visits.
Not like they are saying skin to skin or anything.
They just change the gloves. They just change the gloves. No matter what it is, 120 is not a number which anybody will reach now. There are 80 cardiac surgical centers in Chicago. Out of that, just only 20 centers do this week. Most of them just do 1 or 2 in a month.
Now, numbers have gone down.
Now what is happening is cardiac groups have employed cardiac surgeons into their. Now cardiac surgeons are getting retrained to do angioplasty. They are getting retrained to do coronary angioplasty. So they are trying to get into interventional cardiology. I think they can be done good in interventional cardiology because Ramesh was saying about practical experience helping him in interventional radiology. So also they can be done good. So there is a lot of overlap. But having said that, surgeons basically they routine. Yeah, you know, but it was a very funny thing I tell you. Very funny thing. Shabuddin Rahimullah celebrated cardiologist with statistical. I think he was somewhere in San Francisco, in the USC staff. He did so many nice The funny thing about his center was, for your information, he would get the pressure approximately, right? Leave the sheathing. Next day, the radiologist will come and do the coronary analysis. Radiologist will come and do the coronary.
I also did coronary angiograms.
Basically, I'm talking about cardiology then, now. It will be very different in the future. That is how the science grows. There is no complaints on that.
Right.
I'm only talking in general about specialties of what they are. I would rate internist to the top. Whereas the pathologist, we have the final diagnosis of that. I know any number of instances where after autopsy also they can't give a diagnosis. Right? I will tell you one example. What happened in a clinical meeting, weekly clinical meeting in Origins to Medical Sciences. The Department of Neurology was presenting one death, not tragedy. Finally the professor of neurology said, she was Renu Virmani. Her sister is Renu Virmani. She's a cardiac pathologist in Washington. Very early. Now this Renu Virmani there. At the end of the mortality conference, when the patient died and autopsy was done, she said the cause of death was neurosis. She said in front of all the faculty and the students of all the institute, weekly conference, academic conference, she said the cause of death was neurosis. She went on to become a head of department subsequently. When this happened, she was the number 2. So I have some
What?
And she gets the mail with it.
There's so much change in our own.
in every field there are changes, but I always told my students what has not changed is anatomy. Anatomy, then now it is there. But it has also changed. I realized in the last 15 years it has also changed from a different angle. Like for example, we now bothered about atrial septum, ventricular septum, crista in the atrium, crista ventricularis, AV node, SA node, conduction system, coronary sinus, for example, atrial appendages. We now bothered about those.
Right.
But now they are the
Evolution of medicine that we are talking about.
not changed, but the way you are looking at the anatomy has changed. So also the
We all have 60 years of experience in our medical field. Imagine how much it changed.
yes.
You know, when I started radiology residency, there was only chest X-ray and regular X-ray. Ultrasound barely existed. There is no CT, there is no MR. Look where we came.
I was about to be suspended in Gandhi Medical College Hospital. I tell you something, one anecdote. The cardiologist has done an IVP in cardiac cath on a medical student where we have given an appointment. He didn't say after 3 months. Conveniently, he missed out that part. So I was called into the superintendent, he recommended suspension. I went to the superintendent, I went to the superintendent. This is what I have done. They gave an appointment after 3 months. I didn't thought it is a medical student. What is so great about it? So I did an IVP, which is normal. So he just smiled, he had to wait cardiologist. So he just smiled and said, you do what you do. Then I went to Chest Hospital for an year in between. As a professor of cardiology, started a unit in Chest Hospital. There was a technician, radiology technician, but no radiologist. So I was, I stopped all that when I started getting requests for ultrasound for Pelcosi, right? And then the bearing enema. Then I realized that I'm going overboard, and then I will stop being a cardiologist. I may be branded as something like a radiologist. It's not that radiology is a So I stopped reporting it. But they will still get the X-rays for my opinion. Even now radiologists get the chest X-rays for me. Anyway, that is the story. But some specialty is good in its own way. Not to undermine anything after all. Human body, you call as, liver specialty, brain, heart specialty. Entire patient is one organ. So look at the patient as one organ and try to analyze his problems and interconnect them and give a proper solution. So I would think all these are pathology, internist, and also surgeon. But of them, the most challenging definitely is on any day, transplanting. So if I had a chance, I would have pursued just looking at cardiology is a dull job. If you have done 50 years, if you have done 50 angioplasties, you can make your life easy. But internal medicine is tough. Every day, every patient is a challenge. Cardiology these days, almost every day what I see is diabetes, hypertension, coronary artery disease. As I was saying, it's medicine is the toughest specialty in the entire medicine. We don't in India, we don't have a system. I don't really. I visited some hospitals where we have that program. I wasn't interested because one of my nephew is an artist in Louisa. It will be there. It was started stage near New Orleans, a couple of hours from New Orleans. India, first civil war. I went to the hospital, so he wanted me to show his hospital where he was working at the hospital. Patients were admitted day before. I think they had a heart attack, but nobody has seen this. The guy was in the ICU for 48 hours. Nurse had seen, she made the diagnosis, but not the hospitals. And there was another patient where a CT scan was done. There was nobody to report. That's it. So by the time we finished, Arjun from Bangalore to build one of my student with a pediatric cardiologist in Bangalore. So he started a major teleradiology and back, some of you may know. And he is employed last time I heard 180 to 200 radiologists qualified. And it is a $100 million company 10 years back, maybe now. So he reported that from his side that CT was reported the next half an hour before I finished the round with my hospitalist name. So he showed me that. There was no radiology. Now this is reported from Bangalore. It was from Arjun Center. So much for in the hospital. Your nurses do good job. That I have seen. And your physiotherapists do good job. Your physician assistants also, your medical technician. Not very interesting, except for maybe random professionals like clinicians. I can go on giving many examples because each day I see at least 2 patients coming from US Indian Hospital and 1 or 2 from Indian Hospital. So I know what they have done there, what they have, what are the financial implications, why they don't do it. That's okay. They are large numbers. Many of you are from US, that will be very offending to me, so I don't want to. So thank you very much for the patient listening. But I have respect for every specialty, starting with psychiatry. which I wanted to do, but did not do. But I still counsel, try to start counseling my patients. In a way, I'm also a psychiatrist. In fact, every doctor is a psychiatrist because in their own way they counsel.
Thank you, Raji. When I asked a question about internist, surgeon and pathologist, internist knows everything, does nothing. Surgeon does everything, knows nothing. Pathologist knows everything, does everything, but it is too late.
Remind all of you guys, we are all accessories to some kind in medical profession that happened. Remember, assisting gastrojejunostomy and vagotomy back in those days. We all transited, right? So we must be accessory to the crime. Look what happened. Once you find out this is all Helicobacter doing it, not the hyperacidity or whatever acidity. We're not doing vagotomies, we're not doing gastrojejunostomies, gastrectomies. Imagine the books were written, volumes of books were written. Everybody with surgical experience especially will know. Whatever happened to all those? You know, this is a malpractice, beyond malpractice. All those years. So this is evolution of medicine.
You are saying it is malpractice. It was practice of those days.
Well, you know, but in retrospect, it is malpractice, right? But it is evolution of medicine.
You know, heart failure, now that you I think they will just apply as many leeches as possible to suck the water out. Right? Do you know, it is still being done in Russia. Even now, it is when I was in medicine, for a heart failure patient, which will we used to give weekly mercurial diuretic Mesal, right? Mesal. If you give Mesal now, tomorrow you should be in jail.
Exactly.
Those days, so just check the urine for protein and some cells and gas, then give the Mesal. Mesal is mercury as a diuretic. Because there was no other drug. There were no diuretics. That was right for those days.
We are
So it is not good, it is not right to look back and judge medicine of those days by current standards. For example, I remember from Kolandra Garu, when we used to present cases for clinical discussion, he would say, if we made a diagnosis of cardiomyopathy, he would say, oh, there is not the way this happens. Doing standards of those, as long as you are doing practicing now, according to standards of now, many things have disappeared, many things we have done. So, physicians and surgeons of today, they have to be types.
Couple of comments to emphasize what Raju mentioned. I started my critical care back in 1976. We did in the early stages. I worked with the gurus of critical care because of that particular reason. I look at my own essays, my own CDs, and when I have a doubt, I always go to the radiology department. My radiology colleagues will tell me, Babu, you are only one that come down and talk to us and give the clinical history. Unfortunately, what the radiologists don't have is the clinical background of that particular patient. So they are reading the X-ray, they are reading the CT, they are reading the MRI, not knowing anything about the patient. And not many doctors really bother to go and talk to them and give the background. For example, when I worked in England, when you write an X-ray, you have to give the clinical background of the patient. You have to fill it up. Otherwise, they will not do it. Where in United States, unfortunately, we don't have that. So from that point of view, they are at a disadvantaged position. As I said, I look at my own radiology, I don't look at the radiology reports because there are so many books, some of them are excellent, some of them are garbage. I look at my own and then if I have any doubt, I go down and talk to them. In terms of managing the patients, one of the unfortunate things that is happening is nobody is talking to the patient, nobody is examining the patient other than Raju, and nobody is communicating. Recently I gave a talk, the title of which is The Art of Medicine, History and Physical Examination in the Days of Technology, where people miss simple cases by not talking to the patient, by not examining the patient. The first case was 21-year-old comes with chest pain around 7 o'clock in the evening. They consulted a cardiologist. The guy came, did a cardiac cath, which is normal. 2 days later, they consulted me because the kid still had the pain. Even today, I completely take the complete history. When I examine the patient, I take the close up. Your grandmother, more likely who is not educated, would have made the diagnosis. A rash from back to front. Among people they did a cardiac. And the whole lecture is simple things like that. I had a professor at JNTU in Kakinada came with a car. I got the complete history. I asked him, do you have any health problem? He got married. Babu garu meeru American icharan mee edu vacharandi daggani meetavani meeku endukandi అంటే చెప్పండి బాబు చెప్పాను నేను ఎందుకు చెప్తాను. The gentleman had hypertension. He went to 3 pulmonologists, had 3 CT scans that were not. Nobody did any PFT. And he done AS inhibitors. All the tests are completely nothing. So I told him, mandul manesi, vere mandul imman adagandi doctor garni. I'm not going to treat your blood pressure. Ask him to change this particular group of drugs. వారం రోజులు అయ్యాక మీకు ఎలా ఉందని చెప్పండి, 3 వారాలు అయ్యాక రండి. He was in the habit. ఏంటంటే కనీసం టెస్ట్ కూడా చేయరా. అందరూ అప్పటికే చేశారండి, 3 క్యాట్ స్కాన్ చేశారు. నేను 4వ క్యాట్ స్కాన్ చేస్తే దానివల్ల ఏం రాదు. So he went to start the AS inhibitors. A week later, the problem he had is, he's a professor in the university. He could not take class. He could not complete his sentence. A week later, he felt better. 3 years later, he was completely not. And the psychology after he changed to the point where the patients are telling what they have their own ideology. నేను తెచ్చే మా తమ్ముడినండి, మా అమ్మ నాన్నగారిని కాదు. చెప్పండి చెప్పాను, నేను చెప్తాను. Father is being treated for active TB. No doctor asked about it. And what is boy had active TB. So the art of medicine in certain days is going down. People are dependent too much on technology, too much on the reports. But simple basic fundamentals are lost. One of the people that talks about it is a gentleman by Abraham Verghese, who is originally from Kerala, grew up in Ethiopia. When he was in 3rd year medical student, there was an army coup. Everything was shut down. So he came to New York, finally came to Madras Ramchandra Medical College, completed the MBBS. did his residency in Tennessee, did his ID fellowship. A wonderful speaker, a wonderful writer. He wrote 3 books that are really there. My Country, My Tennis Partner, and Cutting for the Stone. All 3 books are great books to read. he talks about the importance of talking to the patient, communicating with the patient, touching the patient. I met him Foxend about 15 years ago. He was the keynote speaker at American College of Chest Physicians annual meeting. The title was The Role of Perception in the Days of Technology. Go through the whole history of it, a wonderful talk. That is how I got the idea of developing this particular talk again. So the communication to the patient, giving moral support is extremely important. Having worked in the ICU, there is one thing I learned, talking to the patient and family and giving them the moral support. There I know times, a time comes where I cannot prevent death. But if I can help the family to deal with it, that is one. A gentleman came with a terminal cancer. The son and daughter came, I talked to them about no code, no CPR. We all agree to make the patient no code, no CPR. They said, we have a 7-year-old girl who is very close to my dad. Can she come and see him? Those are the days where the policy would say, no children allowed in the ICU. I said, that's fine. They went and brought the kid, left her in my room, and they took off. Now I'm talking with a 7-year-old girl about her grandfather whom she loves so much, who is going to die. So in simple terms, I explained everything. And she asked me, is grandpa going to make it? I said, no, she's going to die. Can you deal with it? The answer was surprising. One day everybody has to die. This is a word coming from a 7-year-old girl. Oh yeah, one day I left around 8 or 9 in the evening. 10 o'clock he died. The girl went back to the nursing station and asked, can I have a paper and pens? They didn't understand why she wanted a paper and pen at 10 in the night. They gave it. She wrote, dear Dr. Babu, thank you for letting me see my grandpa. Clearly, against my speech. I still have that paper frame. Those are the things that I enjoy, being the director of the ICU, being an intensive for 15 years. Though human touch is the most important for me, the scientific part of medicine. If you have pneumonia, you know how to treat it. If you have a heart attack, you know how to treat it. But supporting the family, touching the patient is an important thing that I've done for my patient. Thank you. Everybody ready? Let me